Hello, guys. I hope you can all hear me very clearly. My name is Rizwan. We're just doing an AMC clinical scenario. Hi, hello. Who has turned the camera on? Thank you for turning the camera on because otherwise I would know or see anyone who's on. So good to have you and see your lovely faces. Beautiful Sunday evening. For some reason, it's raining in Sydney. I'm not sure really where the rain came from, but it looks like it's crazy. Dr. Farwa might have something to talk about. Dr. Farwa has been teaching with us for a year or more than a year, I think. And I think she may have something to say. So, Dr. Farwa, anything that you've got a feedback? And Dr. Simra is here. Hi, Simra. And Dr. Farial might be here. I think she's got, oh, there we go. Dr. Farial is here as well. Okay, everybody's on board. All right, excellent. All right, guys, I know that your time is precious and I'll just jump right into it. You see the screen, just nod your head.
Yes.
Wonderful. All right. Okay. Nod your head. I'm like commanding there. So, look, we're starting our AMC clinical course again. The first session is going to be on 31st of August, and it's going to be both morning sessions and evening session. And I thought that I'll just do a quick intro as to what the things are, what's changing, and how things are going to be. All right. So, I thought that would be a good way of just summarizing and showcasing what the teaching is all about. So, without further ado, you all know about AMC clinical structures. Obviously, you may have done it before, or if you haven't done it before, then you're planning to do it. And you've got a date, hopefully, before April, because I think all the dates are already booked till April, and the May dates are not yet announced. So, obviously, it's 16 station out of which 10 stations needs to be passed, and it's 8 crucial minutes of your performance. And that's what we're going to focus on today, your performance in those 8 minutes. And it's kind of a standard OSCE performance time. When I was doing my fellowship exam and AMC clinical, it was exactly like that, 8 minutes of performance time. Now, in an online format, which all of these exams are till April, nobody knows what's going to happen after May, but I presume for the rest of the year, they're all going to be online exams. You may have either a patient who is trained to be a patient or an actor, or it's going to be like a video presentation of some sort. And everything hinges onto either a history, examining the patient, coming up with the diagnosis, and making a very consolidated, well rounded management plan. And obviously, when you make a management plan, you need to counsel the patient, you need to educate the patient, which we often tend to forget, even though we tend to do that in our practical life anyway. So I thought that, look, we need to make sure that this is a part of our commentary. So we're not missing out on that. To be honest, I always maintain that AMC Clinical is the easiest exam to pass. And I repeat that it is the easiest exam to pass in those 8 minutes, provided you're able to segment and cohort your 8 minutes and use them very effectively. So just be sure. Let me just give me 1 second. I think I've got Dr. Farwa here as well, and I hope. Oh, Dr. Farwa, whatever your name, what's your name? Just give me a second. All right. I've admitted all the people. There are about 33 in the waiting room, I think. So if Dr. Farwa is joined, she might be there already. Dr. Farwa, have you joined? I think she might be joining. Anyway, so what's different about 2024 in terms of updates? Well, as I said, the dates are full. The May dates are not announced. When they will be announced, you'll pounce on them like a tiger because you want to get those dates early on. And I always maintain that, look, AMC Clinical has got much more importance than any other sort of exams. When it comes to WBAs, it improves your applicability to all the jobs, all the hospitals. WBA is a job. WBA is a job. So if you're trying and you're struggling to find a job, WBA is not going to be something which you're going to get as a first job. You may, but most of your colleagues that you've had a chat to, in my hospital, we've got WBA cohort as well. But most of the people who are giving the preference for WBA program are the ones who are already in that job for at least 12 months. And once they've shown their commitments, that get taken on. So AMC Clinical is always a good idea. Now, all exams are going to be online, and it's uh, February to April dates, as I said, are online announced. The physical examination component, which there's a lot of anxiety, it's on as per AMC website, is tested at a higher level. What is meant by a higher level? That there would be a lot more details. You'll be interacting with the patient who might be an actor imposing as a student, and you have to explain the entire steps of your clinical examination of the cardiovascular system, the foot, ankle, whatever it is. Okay, and you have to also embed that physical examination finding with your reasoning why you're doing that examination. You have to tell the actor what diagnosis are you able to filter through that examination based on the positive finding, or you might not be able to come up with a positive finding. It might be just going through the nuances of physical examination and then saying this is what I'm going to do. Okay, so far so good. And as I said, it could be an interaction between the medical student, followed by the patient or a healthcare provider. And there will be a prompt timer. So there would be a task in the physical examination or any other examination, and there will be a task to move on. So that's your prompt timer. Move on to the next task. Complete your physical examination. Now start talking to the patient, explain what your findings are. Okay, move on to the next task of giving the management plan. Move on to the next task of giving the diagnosis to the patient, whatever the next task is. Now, this is something new for me. I was checking up the AMC website. You're allowed to write notes on a blank piece of paper, but not during the reading time or rest break, only during the actual scenario when you're conducting the scenario. So I often find writing notes can be a little bit confusing because you're focusing on your note and then you're reading the scenario, and that it might get just double information and confuse you even more. So it's always good to have key concepts in your mind and then go for it. And I'll tell you how to go about it. Okay. And yes, mobile phone on silent. It has to be on you, just because if your connection drops, the AMC will contact you and your phone is on silent, so they would have no problem reaching you out. Okay, so I've got a scenario for you. Does anybody feel like doing a scenario? It's a very easy scenario. And trust me, if you do it here, you'll do it well. And once you've done it, you don't have to prepare it again. Very easy. Anybody, and I'll help you. How cool is that?
May I?
All right. Okay. May I? Did I hear may I?
Yes.
Okay, go for it. What's your name, please? Dr. Ina.
Yes, my name is Inna.
Dr. Kim,
Should
go for
I?
it.
Yes. Mr. Golding is an 80-year-old gentleman who has been to the hospital with a chest pain for past 30 minutes. And he has a history of diabetes and hypertension. His ECG is known and has been given aspirin and glycerinated by diagnosed after discussion with a senior doctor. Vitals is BP is 150, rise 100, heart rate is 67, and saturation is 96. So BCL is 12.2. So take history from the patient. Yes, Mr. Golden, when starts your chest pain, and I have to ask location of chest pain, and is radiate to the jaw or the back. Did you receive some medication during this? And
Okay,
did you
excellent.
yeah.
Yep. So obviously, this is a patient who's coming with chest pain, 30 minutes. He's got a history of diabetes and hypertension. So we won't obviously do it to the time, but I'm just quizzing you. What's your basic sense? What's wrong with this patient, Dr. Ina?
So initially, I don't have ECG, right?
Oh, you got an ECG on the right side, no?
Oh, yes. So when I see the ECG, I'm See
Let
that
me see.
immediately 2, 3, and I there.
Yep.
That's the elevation. So probably it's an inferior MI.
Very good.
Yeah, and and it's a occlusion of right coronary artery.
Wonderful.
So
So now let's
yeah,
focus on the vitals. Hypertensive,
mm,
normal blood pressure,
hypertensive,
sorry, normal pulse rate. Oxygen is
and
okay. Blood sugar is elevated, which is kind of expected because of blood sugar. Now, what are the tasks? History,
yeah.
explain the cause, and management. All right, let's do that
Mm,
quickly. Dr. Ina, do you want to ask me a question? Imagine that I'm Mr. Golding, I'm 80, and
yeah.
why don't you ask me some key questions and I'll try answer them.
Take history from patient. Okay. Um, did you chest pain location of chest pain, and uh, how long does it take?
How long does
And
it take as in?
yeah, and does it
No,
severe than previous?
hang on.
Yeah.
Let's imagine that you're in an exam scenario, Dr. Ina, and I'm the patient. Why do you want to do
Mm,
that?
I need help, I think.
You will need help, but let's start off like you're in a real exam scenario, okay?
Okay.
Or does anybody
Okay.
else want to have a go? Dr. Carlos, you want? Oh, Carlos, let's go for it.
Hello, doctor. How are you?
I'm good, and thanks for having a very good mic system. I can hear you very clearly.
Okay, thank you.
Can you hear me clearly?
So, yes, I can hear you clearly. Can you?
Exactly. Let's do that. Yes, I can hear you loud and clear. Let's do the scenario quickly.
Okay, so good morning, Mr. Goldwyn. My name is Dr. Carlos. I am your doctor allocated today. So, I'm understand by the nurse that you've been having some kind of chest pain for the
Oh,
last
yes,
30
doctor.
minutes.
It's dreadful. 30 minutes is like an elephant on my chest. It's just, I haven't had this kind of pain ever in my life. It's just so bad.
So, you're telling me this is the first time it happens to you,
Oh, look, I
right?
was getting some sort of pain, which I completely ignored in the last couple of weeks when I was climbing upstairs and doing some steps and walking. But now, today, in the last half an hour, this pain is excruciating. It's heavy, it's going into my neck, it's making my arm go numb as well. I don't know. I think I might be having a heart attack. I don't know. I'm very worried, doctor.
Oh, I see. Is there any other symptom might be arising beside your chest pain, like I don't know,
So,
difficulty to
doctor, I'll tell you, I was
breathe?
mowing my lawn. I was mowing my lawn and started feeling that same pain that I have been avoiding for the last 2 weeks. After that, the pain got stronger. Normally, the pain goes away when I rest, but this pain was not going away. It was getting heavier and heavier and heavier. And it's come to a point where the severity of this pain is about 8 to 9 out of 10. It feels like there's an elephant sitting right there in the middle of chest, and it seems to be radiating, which it never did before, into the left side of my neck and into the left side of my arm. And it's also making me a bit of short of breath, which is also very unusual for me to have this kind of symptom. And I'm not sure exactly why it's all that happening. I haven't had this combination of symptoms before, and it's all within the last half an hour after I stopped mowing my lawn.
Okay, I see. So you and you're telling me that this been happening for 30 minutes, and you already
Last
got
30 minutes, yes.
some aspirin and yeah, and you already got some aspirin and some
Yeah, look, my wife
sublingual
called the
tablet
ambulance guys and they
given
gave me
by.
some aspirin and GTN, and that has helped the pain. Now the pain is about 6 out of 10, but I can still feel it quite heavily and strongly.
Yes, I see that it's a very concerning symptom. So, Mr. Goldwyn, for what I see, your blood pressure is a bit high. It's not normal. It's 150 over 100. Your blood sugar raised as well, but at this moment, it might not be the main concern. But what I see on your ECG is that there are some changes on the ACG that might be related with some cardiac event. So I think that is sensible for us to keep you in observation, maybe take some blood tests to check how your cardiac enzymes are at the moment. We might have to start some other additional medication to help you deal with the pain and also with the anxiety that all this event is causing to you. And yeah, we need to just to
So
roll out this
what is going
heart
on with
attack.
my doctor? What's going wrong with me? Do you think I'm having a heart attack? What needs to be done?
Well, this is a real possibility. You might having a heart attack because the chest pain is very characteristic of a heart attack. It's also a chest pain that is not fading away with resting as it has been happening the last day. So this might be becoming as something which is with the potential of being a serious thing. So yes, we have to take you in and we have to get you an observation, take your blood test, start some medications to prevent you from getting a further damage on your heart. And if we can rule out a cardiac event, that would be awesome. But if it turns out to be a real cardiac event, we might need to proceed differently, like having a consultation with a specialist, doing a catheterism, yeah, but at this point, I think that it's sensible to take you in the room and start some medications for a possible heart attack.
All right.
And
So,
yes,
doctor,
because you also
do you think it's serious? Do you think I need to call someone about it?
I'm not gonna lie to you. I don't want to get you too much worried, but yes, it has the potential of being something serious because you have some medical condition, hypertension, diabetes, your age. I mean, you're in an age where these events are can happen at some point. And what most concern me is that this pain is not going away, even though you are resting. So
Okay.
that's
All right.
kind of a red flag we need to take
Okay.
care.
We'll stop it here. Thank you, Dr. Carlos. Is there anything else you'd like to do? So, if yes, your clinical scenario, you're doing an exam, these are the three tasks in front of you: history, likely causes, and management plan. Is there anything else that you'd like to say, do to conclude this session?
Well, in the real exam, do they give you all the physical examination, or I mean,
They'll give
is
you
all
enough.
that?
Yeah, they will give you enough to make up the diagnosis and come up with the management plan. So I think in terms of ECG, blood sugar, they've given you past medical history. There's enough there to make a very solid working diagnosis and two differentials at least, right?
Yes.
Good, good. Okay, we'll
Okay.
stop there. Okay, so you're all right. However, I think you've got to understand the simpler the scenario. This is what I called a simple but a complicated scenario. What do I call it? Simple but a complicated scenario, because the simpler the scenario, the expectation is much higher. And I'll tell you why. Everybody got it right. This is an inferior myocardial infarction because of ST elevation in 2-3 in AVF with the reciprocal changes in the anterior septal leads because of block of RCA. Everybody knows that for a fact. There's no point denying that fact. This patient, given the symptomatology, is having an acute myocardial infarction. Everybody on the same page?
Yes.
Perfect. He's got the right risk factor. He's got diabetes. He's got hypertension. He's hypertensive right now. If you ask him correct history, so I would be interested in knowing his medications, about his smoking history, about his family history of ischemic heart disease. That's why the first task is very important, because some of the information is available, some of the information needs to be dug out. So if you're not asking about the other risk factors for the heart score, which is smoking, family history, hypertension, any anginal symptoms, or whatever it is, to come to to confirm the diagnosis or demonstrate your confirmation of diagnosis to the examiner. I know it's a heart attack because of this, because I know that he's diabetic and hypertensive, and because he's got typical chest pain, and because he's a smoker and hypercholesteremic. The examiner is not going to tick off those boxes, because remember, it's an exam. In real life, you can just look at the ECG and say chest pain, yes, it's having a heart attack. But in exam, you have to show and demonstrate that. So you have to say, Mr. Golding, I understand you're having some chest pain. Do you want me to get you some analgesia? Okay, my name is Dr. Carlos. I'm one of the residents in emergency who's working over here. First of all, look, I'm very sorry to meet you under these pressing circumstances. Let me sort out your pain. My preference would be like giving fentanyl. Are you good? Have you got any allergies? Pain management sorting out. Aspirin and GTN has already been given. Now, let me ask you some basic questions about the pain. I believe that you've been having chest pain. When did it start? Timing is important. Why? Because of that high skill set. If you're working in a tertiary hospital, door to needle time is 90 minutes. Door to needle time between the onset of chest pain and a cath lab. You can't delay on that. So when you're talking to the cardiologist on the phone, you can tell him that I've got an 80-year-old gentleman who's presented for the last 30 minutes of chest pain. So you are actually tapping into their potential of taking cath lab immediately. Understood? So timing is important. Tell me something about the chest pain. I always say, throw the ball in patient's court. Let the patient speak. Tell me what's wrong with you. Oh, I've got chest pain, started 30 minutes ago. It's heaviness, it's central, going into my neck and arm. I've had previous episode, everything that I was telling you in the last couple of weeks, which I was avoiding. But today, after mowing the lawn, it's become certainly more severe, more heavy. It's not going away. I've had GTN. You've got your history out. Quick relative negative. Is the pain going through to the back? No, it's not going to the back. Why? Because we're excluding aortic dissection. Have you had any recent travel or any previous clots in the legs and lungs before? No, I haven't had that, excluding pulmonary embolism. It's still part of your history assessment. Now, have you had any previous cardiac issues, coronary issues before? Okay. It's important because he could have stent blockage. What could be else then? Like, is it significantly associated with short breaths? Have you been unwell with any cough, cold, flu, fevers, or anything like that? Could be pneumonia with pleurisy. Is it positional? Could it be pericarditis? You've excluded all that in yes, no. So let the patient speak.
That's what I
Yes,
want.
no. All right. You've got your history sorted out and go through everything, past medical history, drug history, social history, everything very quickly. You've got 4 minutes, and that's what I call so basically I called it 4-2-2 approach. Okay. So the first 4 minutes, open-ended question, tell me what's wrong with you, closing it by the leading question, yes, no. Then 2 minutes of task focusing. You've done the task number 1 in 4 minutes. Then now task number 2, tell Mr. Golding. Now, whenever is explaining the patient the causes, tell him a working diagnosis, number 1. And number 2, 2 differential diagnoses. That's it. Your job is done. You don't have to and R about 18 list of differential diagnoses. Given the history, based on the history examination and the information which is available to me in terms of the ECG, I believe that you're having a heart attack, Mr. Golding. And that's when the blood supply to one of the vital coronary arteries to your heart is blocked. Okay. Now, this is a life-threatening emergency that needs to be escalated immediately. So you've made a point and the examiner has heard it. Perfect. The other 2 differentials, which are less likely, could it be an aortic dissection, which is a big blood vessels coming from the heart, which could have a tearing pain. But I don't think it's likely in your case because the pain is not going through to the back. Okay. The other differential diagnosis could still be a pulmonary embolism, but I don't think it's valid in your case because you haven't had any previous clot. There's no history or current risk factors which makes you susceptible to having a pulmonary embolism or a DVT or any clotting catastrophes. Okay. 2 differential diagnoses. You're giving the diagnosis and a reason why it is. You're also giving it 2 differentials and the reason why they're not. Okay, Carlos. Then you come to the management plan. Management plan is where the gold is right now. And I don't know the different weightage between the different scenarios, but the weightage in my mind is this management plan. Whenever you're seeing the scenario, an emergency scenario, you need to talk about a definitive management plan first. As I said, it's a time critical emergency. I need to activate the cath lab because that's what you do in the real life. You activate the cath lab. Call the cardiologist. I've got a patient with an inferior myocardial infarction, needs an immediate cath lab. Done. Or at least delegate someone or ask someone to do it on your behalf. Ask for more help. You are a resident in AMC scenarios. You're a junior resident. Ask for more help. And in the meantime, analgesia, journal management, analgesia. What else does he need? He needs Clexane or heparin. Give him Clexane or heparin. The cardiology might want some tyroflavine. Give him that. Whatever the antiplatelet agent, the cardiology want, give him that. Ticagrelor, whatever it is, give him that. Stabilize his condition. Put him on oxygen. He's already had a GT and an aspirin, the loading dose. Ticagrelor is a part of many of the acute coronary syndromes pathway. Give him that as per cardiology preference. Give him Clexane or heparin as per cardiology preference. Now, the other point of management, which is very important, tell the patient again, you're having a heart attack. Is there someone who you want me to call for you? Do you understand what's wrong with you? Okay, I'll call your wife. We'll get your relatives over here. So explaining that to the patient. This is the part that we often miss about our management. And that's the minimum passing requirement. There's not a lot in this scenario, but the way it needs to come out, it's very crucial. So let's move on a little bit further and see what I've written. So this is an inferior myocardial infarction because of the obvious reason of ST elevation in 2, 3, and AVF. And it's got a reciprocal ST depression in 1, AVL, V2, V3, V4, V5. So obviously there's no point denying that fact. Then, task differentials key points, which we've talked about. Now, introduction, we've done that. We've developed a rapport. Simple. You've introduced yourself. I did. You've confirmed the patient identity. I did. Okay. You develop a rapport. Look, I'm sorry to hear that I've met you under these circumstances. I wish we've met under pleasant circumstances. Are you in pain? Let me get you some painkillers. Acknowledgement and plan. What I'll do, I'll quickly take some history from you. Then I'll tell you what's wrong with you and we'll take it from there. That's your plan. Telling the patient what your plan is displaying into the examiner what you're going to do. Remember, you're telling everything to the examiner through the patient. Okay? And this comes with practice. It's not new. So this is exactly, I've made it very simple now, exactly as you were doing. So task 1 is focus history, chest pain history, associations, risk factor for ischemic heart disease, relevant positive and relevant negative. Done. Past medical history we've talked about, drug history we've talked about, allergies we've talked about, social history. Very quickly. You can't be there in terms of past medical history, drug history, allergy, and social history for more than 30 seconds. Quickly. Yes, no. Because the bulk of the money is the history from the chest pain point of view. Because you're triggering the heart pain score cycle there. Task 2 was the working diagnosis. Simple. Working diagnosis based on the ECG and all the risk factor profiling and plus the history that you've extracted from the patient is inferior myocardial infarction, typical chest pain, ECG findings, and all the risk factors. It could be still an angina, but unlikely because the pain is still going on. It could be aortic dissection or pulmonary embolism. Management, general pain management, as I said, in specific is antiplatelet therapy. That ticagrelor, telling the family that this patient, your husband, your father is suffering from a heart attack, will be going to the cath lab immediately. But first management is the gold one. Activate the cath lab. Call for senior help. Okay? It's a time critical emergency. So you're telling the patient, sir, Mr. Golding, this is a time critical emergency. I'll be calling the cardiologist immediately. They need to activate the cath lab. You're telling the examiner that. So when the patient, when the people say they haven't passed the exam, that's the reason. Because they're not articulating the priorities correctly. Okay. And then you go and ask if there's any other thing. Is there anything else you'd like me to tell you about? Is there anyone that I can get you in terms of your family or anything like that? Any questions here? Oh, this is the differentials. So this is my list of differentials. If you're thinking in terms of differentials, always remember the mnemonic. vitamins. Okay. And this is my AMC cheat sheet for pain management. If it's a mild pain, Panadol. Moderate, Panadol or codeine or ibuprofen. Severe pain, morphine, fentanyl or oxycodone. You don't have to remember the dosages, but I've just put it there. Antiemetics, ondansetron. Remember one which works most of the time. This is pretty much the standard antiemetic in Australian health system now. IV fluids. Normal saline is fair go. And if you obviously got hypoglycemia, you can use 10% or 5% glucose. All right. And antibiotics, penicillin, unless and until there's contraindication in terms of allergies or as per therapeutic guidelines. This is your cheat sheet for AMC. These are all the drugs and fluids you need to know, nothing else. Trust me on that. Okay, moving on. So this is the patient that we had. Acute coronary syndrome can either be non-STEMI, STEMI, unstable angina. Unstable angina obviously keeps on giving the chest pain. STEMI is what we're having. Non-STEMI is which is picked up on troponin. So the patient may have chest pain, may not have ECG finding, but the troponin comes sky high. You know the amount of time the patient spends in emergency when they come in with acute myocardial infarction here in Australia? Less than 5 minutes. So everything needs to be so polished and so fast. So that's a heart score. You must have all seen a heart score. So remember, history, typical. Did our patient have typical history? Yes, he had typical history. Central chest heaviness going to the arms and neck. He scores 2 there. His ECG was typical. Yes, he had significant ST deviation, ST elevation. He scores 2 there. Was he typical age group? Yes, 85. He scores 2 there. So it's already 6. Risk factors, more than 3 risk factors. Yes, he had hypertension, diabetes. He was a smoker as well. So he scores 3 there. Okay, so how much is it now? 3, 10 already. Troponin we've not got, but you don't need a troponin. You've already got an ECG. So 10 total score puts him at high risk. So remember the questions that I was asking from the heart score point of view, they were based on this heart scoring system. That's what you're asking for exactly. Okay. And this is obviously the territorial distribution of the coronary arteries. And this is just a flow pathway in terms of whenever you're suspecting, support ABCs, evaluate, physical examination, monitor ECG. That's what Dr. Carlos was telling us about, that we monitor the condition closely. Okay, the question is, what if you get this patient in a non-tertiary hospital or small regional hospital? If the scenario changes and the patient is in small regional emergency where there's no cath lab, what do you do? What part of management would different? Exactly, very good. Thrombolysis. Absolutely 100%, Dr. Albert. So you thrombolyze a patient, but there's a big but, Albert. The but is that you have to first get a patient consent, go through the indications and contraindication of thrombolysis and run it by cardiology. Because sometimes the door to needle time within the small regional hospital to the definitive tertiary emergency might not be that long. But then again, you need to display that level of knowledge that I understand. If the time is more than 90 minutes, you need a thrombolysis for which I need to quickly run through the indications and contraindications, get the cardiologists on board with that, and then I'll thrombolyze you. You don't even have to know the thrombolysis name. Okay. All right. Emergency department, we put him on oxygen, get the ECG done, targeted medical history and physical examination. Physical examination was not a part of that. And obviously, if the patient's chest pain is resolved, we do troponins, call for cardiologists. Now, cardiologists, I say always do it first. That's a practical tip. That's a tip that you need to do for an emergency, or for the AMC, sorry. Okay. The chest X-ray and bedside transthoracic echocardiogram, it's not the requirement for AMC. It's not the requirement at a junior resident level when you're working in emergency department. Immediate journal management, oxygen, IV access, aspirin, GTN, morphine. Obviously, be careful with the morphine, especially if you've got an inferior, if you've got right-sided heart failure, because they are dependent on the preload to generate the blood pressure. If the 12-beat ECG is STEMI, there is only one pathway. Call cardiologist. Do not delay reperfusion. That's where this pathway is going. Okay. All right. I'll just stop sharing my hair. I think Dr. Farwa might be here. Dr. Farwa, you there? All right. Dr. Farwa, you look so different. I could not recognize you.
Hello, sir. Hello, everyone.
Okay. Dr. Farwa might have something to talk about. Dr. Farwa has been teaching with us for a year or more than a year, I think. And I think she may have something to say. So, Dr. Farwa, anything that you've got a feedback? And Dr. Simra is here. Hi, Simra. And Dr. Faryal might be here. I think she's got, oh, there we go. Dr. Faryal is here as well. Okay, everybody's on board. Okay, so Dr. Farwa, first I'll ask you anything further to add on the case that we've just talked about very quickly? I've just done a lightning round.
Sir, honestly speaking, I'll just second you on what you have discussed about that case. It's really important to kind of, highlight the medical emergencies in the first place. If, for example, if you're not able to get the correct diagnosis, but still you are not missing out the medical emergencies, which can be life-threatening to the patient, then obviously you're going to pass that exam. It doesn't make, much difference if, for example, if it is like, a patient comes to you with a chest pain and the symptoms are relevant to STEMI or NSTEMI, and you are just highlighting all the medical emergencies like MI, like aortic dissection and all of that. And in this, if you're missing out costochondritis, no one even cares about it.
Yep, that's
even
right.
if it's the diagnosis. So just make sure that you're getting your list of differentials is pretty much kind of, depictive of the emergencies that you have in your mind that, the things that can be life-threatening to the patient.
Okay. Dr. Simra, you there? I'll make you a host. Dr. Simra, you there? Can I make you a host, please? So that you can, hang on. So Dr. Simra is gone and coming and going.
Yeah, I'm here actually.
Aankh macholi there. Make host. All right. And Dr. Faryal, I'll make you, I don't know. And Dr. Simra can now do everything. Okay. I've just got to attend to something. But I think Dr. Faryal and Dr. Farwa may have some cases. Dr. Simra, would you be able to facilitate that? All right, guys.
Yes, I will do that.
In fact, I just would like to say one more thing. Sorry, Farwa, I'm just cutting you out. I'll just take one more thing.
Yeah.
I had actually made out quite a few cases, but I think I would like to give you a chance as to what's happening. Scenario 2, that is my scenario 2 that I did. Probably we'll do that in orientation. Scenario 3. Oh, I actually made quite a few scenarios. I didn't realize that. I actually got a bit lost yesterday. I just kept on making scenarios. Okay. I think I'm a bit lost again in terms of my scenario placement. It's just going on and on and on. Just give me a second. Okay. I think I've missed a slide. Anyway, look, the point that I wanted to make is that anybody who would like to, join the course, they can join the course going to our website, emergencyfocus.net. Dr. Simra would be able to guide you from that point of view. We've also got a portal. So all the cases are available on the portal and you can join that. Okay. That's not a problem at all. And if I may just show you a quick screen of my portal, that's how the portal looks like. Can you see the portal, Simra? Can you see there? Okay. All right. So that's the portal in which all the sessions and recordings are on the left side. You get an immediate access to portal. You'll have an ongoing access for at least, I think, 6 months, but I'm happy to facilitate and extend the link to the portal, which is all the videos. But I think the main learning, as Dr. Farwa and Dr. Faryal will tell you, is when you come and talk to us. And that's where the main learning is. remember, if you want to pass this exam, you need to speak to Dr. Farwa, and you need to speak to Dr. Faryal, and you need to speak to me and practice as many cases as possible. I'll stop my share here and I'll get Dr. Farwa to put up her slides, and I'll be on my mobile to access that. Okay. I just got to attend to something. Dr. Faryal, you okay with your slides?
Yeah, I'm
Brilliant
fine with
cases.
that.
Brilliant
Thank you,
cases.
Dr.
Okay.
Rizwan.
All right. Okay.
Thank you.
I'll catch you up. Okay. I'll be on the mobile listening to the history.
Thanks.
All right. Okay, cool.
Okay, are you guys able to see my screen?
Yes.
Okay, sounds good. Okay, so first of all, it's I want to talk about one of the most commonest cases that we come across, let it be ED, let it be in our AMC exams, that is abdominal pain, right? So first of all, starting from our first scenario, we have a 65-year-old Meredith who presents to your GP clinic with complaints.
It's like, this question is from in a GP setting, and towards the end of the discussion, you did say like, if the patient develops like the complicated diverticulitis, that means the patient has developed some sorts of complications of the situation. So obviously the first step is to refer them to the tertiary hospital to be able to have the inpatient care. But in our exam, do we end up there, or do we give them the idea of what they're going to be like facing in terms of like, I'm thinking about that, the timing issue. If I have to tell a lot of things, in that case, how do we whether we need to give any kind of or how should we approach if a patient comes to the GP setting, but we're referring them to a different setup? Yeah.
Okay. So very good question. It's more like when, for example, this patient, similar patient, Meredith, it has presented to me with diverticulitis, but she's massively bleeding. She's vitally unstable. Okay. Because of that, probably hemorrhage, or she's peritonitic on examination. Then I would just kind of, tell her about her condition, following all those 4 C's. And then I would say that as it is an emergency, a surgical emergency, probably, if it is peritonitis, then I need to shift you or transfer you. If the tertiary care hospital is far, then obviously air ambulance, or like if it is like somewhere nearby and you think that the patient would be able to kind of, survive this time, then you can kind of, say that I will be transferring you via ambulance to a tertiary care hospital where they would admit you and just outline the basic ones. They'll just make sure that you're not eating anything by mouth, because we have to put your bowels at rest. You will be having IV fluids while you're on your way to the hospital, just to make sure that we are keeping this patient vitally stable till the patient arrives. And once you're there, they will be putting you, just don't mention the names of the antibiotics. They don't even care. Okay, it's good to mention, it would be a plus point, but if you don't have time, just say that they will be putting you on some antibiotics. And if you have peritonitis, probably you will be ending up having a surgery, which we call it as emergency colectomy, where they have to kind of, emergency colectomy, which should be done in the case of the condition that you're having, like peritonitis. And it would be a life-saving surgery for you. Okay. So
Okay. Yep.
just highlight that, like, in points. You would be having enough time. Trust me. It's just like those 8 minutes. In every station, I was able to finish off each and every case of mine within 6 minutes, 30 seconds. Within 6 minutes, 30 seconds.
Wow, that's amazing.
It's more about, the practice as well that you're having. The more you'll talk, the more you'll practice here in our interactive session or with your study partners, the more it would help.
All right, thank you. Thank you for answering that question. So in online exam, they do put in like a timer on the screen while we are in the station?
No.
No.
Don't have any timer.
Or what
the
about
timer
the in-person?
in person, to be very honest, I did my online examination. So in person, I'm not so sure. Even I have heard from one of my friends who have already done this in-person exam, and they were like, I don't think so. They do have any clock or time, or even like watches are not allowed in in-person examination.
It's not in person in 2024 as well. It's only online because the teaching center is under construction.
So with online exam, they don't have any timers. That's for sure. The timer is like the time bomb is ticking in your head.
Yes. I just want like to mention one thing for Farwa and Simra here, because there isn't a correction for that. There isn't a timer, but there is a prompt timer for some cases where they will tell you there is 4 minutes for history. You have to manage your time, like Dr. Farwa said yourself. They will tell you you'll get 6 minutes for this or that task. You have to manage your time. So in my cases that I recently said the exam, they did prompted me like, doctor, your time is up, move to your next task. They did prompted me, but one of the cases in the psychiatry that I filled, the only case that I filled out of my 14 stations, I couldn't hear the prompt timer and I couldn't list the differentials. And I was thinking in my head, like, it's been long. Why aren't they prompting me? I should, like, start saying the diagnosis and differentials. As soon as I said acute psychosis and the time was up, I did complain to them as well. Like, I couldn't hear the prompt timer because of the internet issue. But obviously, it's your luck. So, like Dr. Farwa said, manage your time yourself so that you can't blame any other person. Okay?
That's a
Yeah.
bit of a challenge, I think.
Thanks, Riyal. Yeah.
No worries.
It won't be a challenge. Trust me, it won't be a challenge once you're, on the top of your practice and everything. It won't be a challenge.
So that's good. If everyone is good with the questions, then Farwa, thank you for presenting an amazing case today. And looking forward to you on the board again. Amazing.
Thanks,
Now we are heading to Faryal. Are you ready to share your screen?
Yes, I am.
That's good.
So hi guys, my name is Faryal. I'm one of the residents practicing in internal medicine. Recently cleared my exam as well. So I do have in touch, like, exactly what the online examination is seeking from the candidates. So I would like to present my case, that is a physical examination for today. Or everyone can see my screen, yeah? So
Faryal,
let's talk about.
I cannot see your screen right now. Like,
Not yet.
I think Farwa, you need to stop sharing, and I think then Faryal can start sharing her screen. Yeah, now I can see that. That's good.
Good with everyone? Yeah, so let's begin.
You
So
can
with
just do
physical
full
examination-
screen. Just do full screen. Yeah, that's fine.
Let me just see full screen.
It looks okay though, so that's fine.
Yep. Clear to everyone now? So I know, guys, you've already spent around 1 hour and 40 minutes. So I'll try to be very precise, very quick, because it's just a trial exam. Obviously, we just want to give you the taste of our tutoring so that you join us on this platform. So to begin with the physical examination, I chose this topic so that I could highlight the importance. And in AMC examination, I know as a beginner, I was also dreading to go through the physical examinations. But the lucky part is there are 4 cases in the physical examination that you can nail and ace the exam. So there are 4 cases that you can tick off and can easily pass the exam if you're very well prepared for the physical examination. That's how important it is to have a grasp on the physical examination. And for you guys, online physical examination is a bit tricky in order to grasp the topics, to retain the structure. But if you have become a very pro in like 3 or 4 months, you can deliver the best approach. You can finish the physical examination even like within 7 minutes if you're too fluent. Yeah. So it's just about fluency, grasping the structure and the topic and the content and how you want to deliver it. So in a physical examination cases, there are just basic examinations like cardiovascular, respiratory, abdominal. But depending upon the case, you have to modify your approach every time. For example, there could be different cases. Today we are discussing cardiovascular, and I would show some cases and will tell you what relevant examination they are asking you in the examination, and what AMC expects you to deliver within those 8 minutes. So to begin with, the first thing that you have to do for any physical examination is building the rapport with the patient, medical student, or whoever is sitting. So in face-to-face examination, it's usually a medical student or a patient sitting there. But with online, they have changed the audience. It is a patient, it could be a parent of a child sitting in front of you. It could be a medical student. So first you will tell them, look, hi, I'm Dr. Faryal. I'm one of the doctors in the GP or in the ED. How may I address you? Then you would acknowledge their name and tell them, okay, I understand you're in the ED because you're concerned about your kid having some rashes around the mouth. I'm going to examine your kid. If it's a parent, if it's a medical student, you would tell them, hi, Louis, how are you doing? I really appreciate you coming here to learn today. So are you excited, or which area are you studying in? Just a little bit rapport. Don't waste your much of the time, and just quickly begin. I would tell you the examination with some important landmarks. Please feel free to stop and ask again. I can repeat myself, or else keep the questions for the end, because you don't want to waste your time, even with a medical student. So the basic structure for any physical examination is a wipe approach. Wash your hands, introduce yourself. You have already done. You'll tell the medical student in this case that you're going to introduce yourself to the patient. The P is for the permission, the position, the exposure, etc. E is exposure. Then general appearance, that is how the patient is presenting to you. Then you will come to a specific system physical examination. Any system you would be doing would consist of the inspection, palpation, percussion, auscultation. In cardiovascular examination, I've highlighted the auscultation part because this is the one that is going to give you more scores about the examination perspective. Then you're going to do relevant system P. I put it there because in every physical examination, it's not going to be only cardiovascular examination. You need to put some important points that you're going to do further examination in a patient. Are you guys with me so far? I'm sorry, I'm very fast. Okay. Then to end your physical examination nicely, you just list some crucial findings. So cases could come differently, and I will tell you in the end how they can come. They could be coming as a diagnosis with a differential diagnosis, or it could be coming as listing the crucial or positive findings. So for wipe, let's go in details for the wipe. You're gonna wash your sanitize your hands, wear gloves if it's an intimate or parts examination, like DRE maybe. Then obviously in a cardiovascular case that we are doing today is not relevant. Then introduction to the patient. You will explain the procedure to the patient. Hi, Mr. Smith, I'm going to examine your chest, going to listen to your heart sounds, going to feel the chest to see if what's wrong with your heart. May I have your permission? In this process, I'm going to make you lie down at 45-degree angle to examine you. Do you need any painkillers? Are you in any pain right now? Do you have any allergies I should be known of while offering the painkiller? Then you'll maintain the privacy, give a gown to the patient, tell them to undress themselves, and then maintain a good exposure. That is the exposure of the chest in cardiovascular examination. Chaperone is only relevant in some of the cases, like I told, like when you're examining intimate parts of the patient. You do not need a chaperone in every case. Then the general appearance. You would first begin with the level of consciousness of your patient. Is the patient alert, drowsy, or in distress due to chest pain or due to breathing? If they have any respiratory distress, if they have any cyanosis, that is the bluish tinge to their skin due to the breathing distress. Cachexia. Usually patients with congestive cardiac failure do appear very cachexic, that is the muscle bulk loss. They will appear very thin. Then BMI, or patients with high cholesterol, obese patients do manifest a lot of heart issues. Then hands, when it comes to hands, you will first examine with the nails for the pallor, cyanosis, nicotine staining. Nicotine staining is significant just in case, if obviously smoking is one of the risk factors for our cardiovascular diseases. So you would know that your patient has some few of the factors that can contribute to the heart issues. Then splinter hemorrhages, ocular nose drainway lesions. Guys, I've only placed them because they're relevant to an infective endocarditis case, not for the congestive cardiac failure cases. That's what I'm telling you. I'm going to give you a general approach, but you have to decide according to, based on the case, what things you have to deliver, what things you have to say, and save your time. And rather not to speak like, irrelevant stuff. Then clubbing can be present in congestive cardiac failure. In the palm, you will see if the palmar crease is pale, that demonstrates anemia. Temperature, obviously, for infective endocarditis cases, if there is an infection, the patient's temperature would be raised. Xanthomas are the yellowish pigmentations. They can be plaques around the skin of the arms or hands. In the arm, you will check for the pulse. You'll tell the patient that, look, I'm going to check your, to the medical student, that I'm going to check your pulse by placing my fingers here, and would check for the rate, rhythm, regularity. Blood pressure, we would check and ask the medical student if they know how to check the blood pressure. So in AMC clinical cases, it has been seen that they were expecting you to explain how to take the blood pressure. And in some cases, you have to explain the whole process. So in that case, what is wise enough to do to save your time is ask the medical student, do you know, Laura, how to check a blood pressure? Would want me to explain it to you? In the case that I had, the student told me, no, I'm good, you continue. So that saved my time rather than just going into the detail and wasting your time explaining it. Then on the arm, just also observe for any IV track marks or needle marks. This is as significantly seen for the infective endocarditis patients cases, that you need to see those things that can cause obviously result to rheumatic fever. Then on the face, you will check for the conjunctiva for the pallor, sclera for jaundice. Xanthelasmas are the yellowish deposits due to hypercholesterolemia. Mitral facies is a very tricky finding, and it's usually seen with the patient who have a mitral valve disorders. It could be mitral stenosis or anything. It's actually a bluish tinge on patient's face, and you would at once would realize that it's something to do with valvular heart diseases, that the patient appears this way. Then in the mouth, you'll ask the patient to lift their tongue and check for the central cyanosis. On the neck, it's very important to observe for the raised JVP. In the abdomen, you can do the hepatojugular reflex while you're observing the neck as well, and I'll tell you how we're going to do that. So the next thing is how to measure blood pressure. Like I told you guys, like AMC expects you to now to explain the blood pressure process to a medical student as well. So how we do is we'll tell the medical student, look, Laura, I'm going to place a cuff around the patient's arm, inflate it until it's inflated, and then I'll try to deflate it until I heard the first systolic blood pressure, and then deflate the cuff and give some time to relax. Then place the stethoscope on the brachial artery to listen for the cough sounds, and I would start inflating a few readings above the systolic BP. Then gently deflate while listening to the first sound. That would be the systolic BP for us, and the last sound, that would be a cough sound, that is diastolic BP. So I've written the explanation here, but like I told you guys, just try to save your time and ask a medical student first. Do you know how to measure the blood pressure or not? Do not go in explaining and wasting your time. The JVP measurement, even if you just mention to the medical student to like how to measure the JVP, because it's a very important part in congestive cardiac failure cases. So tell the patient that your patient is already lying at 45-degree position. You'll ask the patient to turn their face towards the left side so that you can observe the internal jugular vein between the two heads of the sternocleidomastoid muscles. And JVP is measured by the vertical height of the highest pulsation from the middle part of the cervical rib. You guys can see here, this is the height. This is usually the vertical height that we are measuring for the JVP. And if it's greater than 3 centimeter, it means the JVP is raised. The significance of raised JVP is obviously in the right-sided heart failure, that such patients would have that. Hepatojugular reflex is another interesting finding. You can do it right here as well, or you can just put it in the structure at the end when you're examining abdomen. So how you do a hepatojugular reflex is you press on the right upper quadrant with the pads of your fingers, and while you do so for 10 seconds, as a normal reflex, there will be a transient rise in JVP. But in a patient with a congestive cardiac failure, until you keep placing your hand on the right upper quadrant, the JVP will stay elevated. So you would know this is a positive hepatojugular reflex, and it's positive for congestive cardiac patients. Then coming to the examination of a particular system, like in CVS, first we'll be inspecting the chest now for any scars, chest wall deformities. is spider nevi. Spider nevi could be present if obviously there is portal hypertension affecting the liver as well, in the congestive cardiac failure, especially in the right side heart failure, and they could demonstrate those as well. Then we will be looking for a visible apex beat. Apex beat is usually located around the fifth intercostal space in the mid-clavicular line. So now the significance of chest wall deformities is that the apex beat could be displaced because of any chest wall deformity like kyphosis or scoliosis. To palpate the apex beat, first warm up your hands. Tell the medical student, I'm going to warm up my hands first before I'm going to touch the patient. And I'm going to inform the patient, look, Mr. Smith, I'm going to touch you now. Are you comfortable? Ask them for any pain at the beginning. And obviously, if there is any pain, you'll offer them painkillers and do not palpate on the side of the pain. But obviously, in this case, there was no chest pain. Then to begin with, you will place your pad of the fingers. This is the flat surface of the fingers on the patient's chest, specifically around the fifth intercostal space in a mid-clavicular line to look for the apex beat. So usually apex beat is not always present in even normal people. It's only the 50% of times that it's available. So do not be scared. But in the for the exam purpose, we have to mention this. So do not talk into that. So we will palpate the apex beat, and the most important part that we are looking is for the displaced apex beat. So finding the normal apex beat is not the mission here. It's actually if it's displaced or not. So a displaced apex beat is a positive finding in a cases of cardiomegaly, congestive cardiac failure, chest wall deformities, pleural effusion, tension pneumothorax. Then the other thing that we are going to see is a parasternal heel. So with the heel of our hand, this is the heel of our hand, we will feel around the pericardia for the rumbling sensations. These could be found in any valvular heart defects. A palpable thrill would be felt around the valve areas as well. So the 4 valve areas that you need to mention in the examination is that mitral valve, tricuspid valve, pulmonary, and aortic. So how you would do it is just tell the medical student simply, look, we are going to examine the patient, the palpate in these particular 4 areas, and will auscultate in these areas as well. While you tell these 4 areas and signify to the medical student that you're going to palpate and auscultate, this will help you not to repeat these things again when you will come to the auscultation, because you're already specifying the student that you're going to auscultate and listen to the heart sounds in these areas. So mitral valve in 5th intercostal space, mid-clavicular line, tricuspid 4th or 5th intercostal space, left lower sternum, pulmonary valve, 2nd intercostal space, left sternal border, aortic valve, 2nd intercostal space, right sternal edge. So percussion usually is not very important in heart examination, but the only reason that I mentioned it here, it could be you can briefly tell the medical student that percussion of heart can be useful only to estimate the size of the heart, like in cardiomegaly cases or pericardial effusion, but it's not very relevant in this case. So let's just skip this one. So auscultation is very important in cardiovascular examination. And like I told you, when you're palpating the chest, specify to your medical student the 4 valve areas that you're going to first feel and you're going to listen, so that you don't have to waste your time repeating yourself again and again. We're going to put the stat around the heart, around the pericardia, and we'll be listening for the S1 and S2 sounds that are normal, and the extra heart sounds, the added heart sounds like S3, S4 gallop rhythm. This is significant finding for heart failure. A carotid bruit that is around the neck, you'll be listening it with a bell of your stethoscope, and carotid bruit is more significant with the cases of aortic stenosis. Then mitral valve, you will begin with bell first and then auscultate with a diaphragm. Then tricuspid, pulmonary, and aortic, rest of the valves can be auscultated with a diaphragm. And just mention to the medical student quickly, if a murmur is heard, you will assess the murmur for a timing, whether it's a systolic or diastolic murmur, area of greater intensity, at which part of the valve the sound is greatest, the loudness is graded from 1 to 6, and radiation, if it's radiating anywhere, like the mitral murmurs that can go around the armpit, the aortic murmur that can go around the neck and present with a carotid bruit. So these are the areas that you need to auscultate. This is the bell of the stethoscope, the diaphragm. The bell is required to auscultate the carotid bruit, and the mitral is murmurs as well. Then comes the relevant system examination that you need to include. That could be a respiratory examination, abdominal examination, or a lower limb and sacrum examination. So with the respiratory examination, since it's obviously is a significantly a cardiovascular case, you do not need to go in detail of the extra system examinations. Like for respiratory, you will just significantly mention the finding that is positive in a congestive cardiac failure case. For example, bibasal Krebs. So you'll tell your medical student, you're going to auscultate anteriorly and posteriorly of the chest, comparing on the different levels on the both sides. Okay, it's like a step ladder pattern. First, you're gonna auscultate on the right side and the left side on the similar position at different levels, comparing on both sides. There could be a pericardial rub positive as well, and you just need to mention. Don't go in details in such cases because we only have 8 minutes. Then abdominal examination, the significance of mentioning abdominal examination in a congestive cardiac failure cases in particular is the liver examination. You will tell a medical student that you're going to start palpating the abdomen for the tender hepatomegaly. And how you do it is you will palpate with the pad of your fingers and will start from the right lower quadrant, moving every time on expiration and asking the patient to take deep breaths, and on inspiration pressing into it and moving upward to feel for the lower margin of the liver. And you can measure the liver span by the same method, or you can do the percussion method with where it is to strike your middle finger on the other third finger of the hand and just to listen for the dullness of the liver. For the upper margin, we would start it with from the third intercostal space in the mid clavicular line, and for the lower margin, we can start from the right lower quadrant, moving towards the right upper quadrant to here for the dullness, and measure the liver span with a measuring tape. Sacral and pedal edema are very important for the congestive cardiac failure cases. You can look how it's significantly, it's pitting here, and believe me or not, usually patients do present like this with such severity. So for the edema, especially on the shins, you will check if they are, what is the extent of the edema and if it's pitting or non-pitting. And mentioning this is only enough for the medical student. You don't have to go in the details of the examination of the lower limbs. So to begin with some cases, anyone has any questions? Do you guys want me to repeat anything?
I have a
If
query.
everyone, yeah,
Yeah.
sure, go ahead.
Like since this is an online examination, so there won't be any real patient. Like, so how are we supposed to demonstrate all these things?
What I did was I was demonstrating on myself. Like when I told the person, like I'm going to percuss the abdomen, I was sitting in such a spot, like the camera was on me, and I would mention to the medical student, look, this is the dominant hand that I will be percussing with, and this is the non-dominant hand that I will place on the right lower quadrant, and I will strike my third finger on the third finger of my left hand like this to here for the dullness, and I will go up like this, like I was doing. Let me show you a bit. I showed the medical student like I'm gonna do like this. It's very
Okay.
simple. Or else most of the people I've talked to, they said they had a doll with them and they were demonstrating on that. But don't worry about that those things, because it's just gonna like significantly waste your time. It's bad because the purpose of a medical student being present in the examination is that you don't have to go in details and you don't have to worry about explaining everything. Before, the examination was used to be like, there are some scenarios where there is a parent rather than a medical student, and you have to explain the examination to the parent as well. There are certain tasks. So in those tasks, you have to be as simple as you can with your wording. So you do not have to use any medical jargons. But with a medical student, it's like very easy to communicate. You can obviously expect the medical student to know the terminologies and the anatomical landmarks as well. So do not worry about like, how you will demonstrate it in an online examination. Just be sure that you're fluent and you're clear enough. Your medical student may have some questions. So try to be as clear, try to explain them as much as better you can. Or like, for example, in a musculoskeletal examination, just for instance, you can tell the patient, oh, look, the elbow is like this, I'm going to turn it like this or that. This is flexion, this is extension. So those things you can show and demonstrate, okay? When we'll come to those physical examinations, I can demonstrate as well to you, okay?
Okay, thank you.
Is that clear, Kanan?
Yeah, good.
No worries. So guys, if no one has any questions, let's start with the cases. So the first case that I had been focusing while talking on the cardiovascular examination is this one. A 40-year-old patient admitted to ED with shortness of breath worse on lying down. Past medical history significant for hypertension, cabbage an year ago. Task is explained serious examination to the medical student with anatomical landmarks. Or there could be other task in a way that they can ask you to perform relevant systems examination. So when you see this sort of a case, the first thing comes in your mind is rather cardiovascular examination is actually a respiratory examination, because the patient is coming with shortness of breath and you will think, oh yes, it's a respiratory examination because there is some issue, isn't it? Can you guys point out to the positive factors that will guide you towards the cardiovascular examination? Can you tell me, can you pick out the points that will help you to actually realize this is a cardiovascular case?
Hypertension,
Orthopnea.
Exactly.
and
So
cabbage
there's
history.
orthopnea. Yeah. Good job, Zahid. Thanks, Kanan. So that's the thing. Those are the positive things that are actually guiding you. Okay. In a respiratory case with a shortness of breath, there would be rather something different. There would be like a smoking history. There would be like, as the patient used to had asthma, used to take these puffers, but now he did not had anything. He had allergies. So that will guide you towards the respiratory. But like I told you, when we're doing any of the system, there needs to be a touch of different systems as well. Like for the congestive cardiac failure, let's talk about this case in particular. We will be talking about the cardiovascular system in detail. We will be touching the respiratory system as well, telling the patient that we are looking for bibasal Krebs or a pericardial rub. We will be touching the abdominal system as well to tell the medical student that, look, we are looking for a tender hepatomegaly, that is a positive finding in a congestive heart failure. Okay. And pedal edema, that is important. So you're not actually going in detail for the rest of the examination, but CVS is going to be a basic examination in a part, and the rest of them you have to touch those topics to complete your examination. And there will be some cases they will ask you to list the diagnosis or the differentials that you're thinking for SOB. Or it could be a task like, you have to list the positive findings of the case to the medical student. So for the second case, a 45-year-old man presenting in ED with complaint of acute onset chest pain that started 30 minutes ago, radiating to tip of shoulder. The patient also has nausea and sweating, vitals are stable. You have to tell the relevant PE to medical student. So guys, what do you think this case is? Sorry?
Acute coronary syndrome. So it could be pericarditis because it is improving on leaning forward.
Yes.
Oh,
yes.
sorry. It's like third case. Sorry.
It's the third case. The third case. So these two cases that has been coming in the last year have been a bit of confusing. For the ACS case that has come, it only came like once. And we're not sure even if it came or not, because people had been confusing the acute coronary symptom with the pericarditis case. The pericarditis case has come in the physical examination, but you don't have to be afraid. As long as you know the structure, as long as you know what you're looking in the general appearance in the CVS examination, you don't have to be afraid of like changing the any basic things. Because Kaushik, can you please mute yourself? Thank you. So guys, do you have any questions about these three cases till now? Any questions? So let's move to the case number 4. Yep, please go on.
In terms of case 2 and case 3 for both of them, is in the exam, is the major issue finding the diagnosis, or is the major issue discussing the differential diagnosis of acute chest pain?
So look, usually the task that comes in the online examination, the good thing is they're not every time asking you for the diagnosis or differentials. They would tell you like this patient is coming with a chest pain and it's getting better on leaning forward, and he had a flu-like symptom almost like 1 or 2 weeks ago. So you would know it's endocarditis or something. They would specify actually, and you can continue doing the cardiovascular examination. So you don't have to be afraid there. But there will be some cases there where they can ask you, just like, prepare yourself for the worst that AMC can put forward to you. So just in that case, you need to put the diagnosis and differentials in your list. Leaning forward, the pain gets better. The first thing in your list could be pericarditis. Chest pain, it obviously could be ACS, acute coronary syndrome. So you can explain to your medical student, look, the basic thing that I'm thinking, my provisional diagnosis, and likely in this case is pericarditis, but I'm thinking about some other dangerous or more life-threatening causes of chest pain as well that I don't want to miss in this patient, like acute coronary syndrome. I am also thinking about pancreatitis pain that gets better, happens in epigastric region, and gets better with leaning forward. Like just list 3 or 4 differentials as well if a task comes like this. But in my opinion, like, usually what cases I had in the exam, they did not ask me to list the diagnosis as a specific. They did ask for the differentials, and differentials would be easy. Once you're in touch with the topics, you know what sort of pain it is, you would be easy for you to list them. Okay, Mr. Machari?
That's fine. Thank you.
No worries.
Actually,
Hi. Okay, so I want to ask one thing. So obviously in the online exams, you are just going to explain the procedures of the physical examinations to the medical student. So
Yep.
how do we come to know about the positive findings based on which we'll, draw a conclusion regarding the differential diagnosis?
So in online examinations, unlike the face-to-face examination, you wouldn't get actually any positive findings. But what you do, you'll tell the medical student, look, in a congestive cardiac failure case, I'm looking for these positive findings. I have the last slide saved for that to her. I'll show that to you, okay?
Okay,
So,
thank you.
no worries. Case number 4, 25-year-old man coming to ED with chest pain, feeling unwell. He had a sore throat, flu-like symptoms 2 weeks ago. You have to present the physical examination to the medical student. You have to list the findings, the positive findings. Could be a diagnosis or a differential diagnosis task. So guys, this case was a bit tricky that had been coming the last years. It was actually an infective endocarditis case. It was a rheumatic fever case leading to acute congestive heart failure. So here, saying the diagnosis was the trickiest part because people were saying only one thing or two things. Like usually in our minds, we have this concept that the diagnosis would be only a single thing, a single label. But the diagnosis could be an extended part. Like, you have to mention like, look, this is to this and secondary to this. So in this case, it was congestive heart failure complicated after a rheumatic fever. So if you would have said that they were scoring you fine with that, and obviously you have to get the concepts clear so that you can deliver such diagnosis. And obviously it's not like, easy thing as a beginner. And I know I can see the expressions right now, a bit worried, but don't worry, when we'll come and discuss this case as a specifically, we can go through that. The reason of mentioning these cases here is to obviously lure you guys up here that we are going to discuss these cases in the actual classes. So you do join us, okay? The other case was a rheumatic fever case as well in the pediatric CVS examination. And it's almost the same as the adult. There's nothing different. But sometimes you have to mention about the murmurs, how to auscultate the murmurs as well. If I had gone in details of the murmur examination right now, it would have gone like too far. I don't want to stretch the time. We can discuss those things later as well. And like I told, like you don't have to put everything in the examination in the 8 minutes. In the congestive heart failure, you don't have to specifically go in the murmurs and doing the maneuvers for the murmurs to examine them. There is a different case. This one is the case for the murmurs, where you have to do all the maneuvers as well and explain them to the medical student. So as we'll go along the class, hopefully we'll be there with you guys and we can discuss all those things as well. Tuha, so this is the slide you were asking for? So for the case number 1 that we discussed initially was a congestive cardiac failure case where the patient is coming with a shortness of breath, with orthopnea, he has hypertension, he has a history of a cabbage done a year ago. So when you come at the end of like finishing your case, you need to give a good closure to your case as well. Like if you guys would have heard, like, when you do a medical case, you tell your patient, like, the SADMA, smoking, alcohol, you ask about past medical history, past surgical history, family history, and thank you for all the information that you provided me. So such a closure you need in the examination cases as well, where you will tell your medical student, and believe me, you will have plenty of time. You will tell the medical student, look, Laura, now we have done with the with the physical examination. Do you have any questions for me? If the student does not have any questions, then you'll begin with, so I'm going to tell you some positive findings that we expect in such a case with a heart failure patient. So you would just list these things. Obviously, you are not getting any positive findings because it's not there. There is no patient to get those positive findings like a face-to-face examination. But rather, you just tell the medical student what would you expect. So a raised JVP to begin with head to toe, a raised JVP, a positive hepatojugular reflux, visible apex beat in the chest examination. When you auscultate, you listen for S3, S4 gallop rhythms, bibasal crabs in the lungs, tender hepatomegaly, and pitting edema. These things, if you mention, the examiner will be happy. They'll know that you know what you're doing in the examination to actually find the positive things. And this is the purpose. Obviously, they have changed the pattern of the examination, but they're expecting the similar things that they were expecting before. So the expectations haven't changed. It's just the delivery that they expect, and that's changed for you guys. So I hope I was too fast, I think, but I would make things clear as well. I'm sorry I didn't go in details for lots of things. There is, like, for every topic, there's particularly a bit different examination, and we can discuss those things, itsy bitsy things in detail later in class. So hopefully you don't have any questions for me, or was I like too much fast for you to retain anything? I know it was.
I think that's pretty good and clear because you should be very focused when you're doing your clinical exams, because if you're going into too much detail time frame, you're losing that. And if
Exactly.
the examiner will keep prompting you, you are getting panicked, and that will let you to fail that case. So one other thing is focused, and that's good that Faryal is very focused in telling about the things which needs to be taught. And of course, it's an orientation class. We just want to give an idea about how it's going to be. And when you are going in the course, which is starting, I'm going to tell you from 30th of January, that would be more focused and more clear as well. So that's great.
Guys, do you have any questions till far? Anyone wants to like touch any of the findings or anything specifically from the examination perspective, or want to talk about the online examination? I'm happy to tell you.
So our course is from January 30th to April 27th, right?
Yes.
Yes. I'm going to show you on the website as well.
Okay.
Just 1 minute.
So as you know, currently till May everything is booked right now, right? So what do you recommend? Since what I've heard, they are opening the seats in February, right? I'm hoping that is the correct information for clinical seats. So what do you recommend? You recommend to book the seats right now, or just wait for some time and book?
Depends upon how much you're prepared already. If you already have gone through your content, I would honestly say if you feel like confident that you've covered the theoretical part and you just have to do the revision and do the physical examinations, even 2 months would be enough for the revision and perfecting your role play skills. But if you've been like studying for a long time, don't procrastinate it. Try to attempt the exam as soon as possible, because obviously as much as time you keep spending like procrastinating and trying to perfect yourself, it's the opposite is actually happening. You're not perfecting yourself, rather you're just forgetting things again and again, and you have to revise them again. So better to just take the exam when you feel you're confident that concepts are fresh, when you know that you have covered a lot of things. Because this exam in terms of in comparison to AMC1, you cannot change the date. You have to take the exam.
Okay.
Can I say something about it? Kanan, I would like to say that just if you are like, planning to book your exam, just make sure that you at least give one trial exam before booking your exam, just to make sure that where exactly you're standing, because sometimes we are not able to kind of judge where exactly we are standing in the real time.
Yeah, true.
So just make sure that you're giving that one of trial exam, and then whatever you think about booking your exam date.
Thank you.
No worries.
That's good. Purva and Priyal, thank you so much. It was great. And looking forward for that. And yes, I think one of the thing I want to say that AMC1, we booked the exam because we know like we have got an option to change the dates, right? But I have seen candidates booking the exam for AMC2 without even not knowing anything about the exam. And in 4 months, that just the fear that we will not get the rates, we just want to book the exam. The good thing is that in the last 2 years, AMC was tough with the dates, and you have a long waiting list for AMC Clinical. But this year, things are getting much better. Even if you can just email them and put yourself in a waiting list, they will definitely give you a chance. So at least 2 months of at least getting in a basic idea and structure about the exam, giving a trial exam, and then moving forward. Because it's just like a 1-1 situation. Okay, I just want to pass the exam in one attempt. And being a career counselor myself, if you have done AMC2 exam, even if you have a 5 or 6 year off gap, job is 100% guarantee. So clinical stands out you despite of if you have a recent experience, but if you have a clinical exam passed, you will touching the job market. So the job campaigns are starting from June, which will go till next year, like January. So you still have to focus on one thing, clear your exam, focus on that, and then move forward. I'm gonna share my screen and I'm going to tell about when you go to Emergency Focus Careers website, it's Emergency Focus over here. And then you can see that our course for AMC Clinical is here. You can check the details and bookings and then move forward. We are starting it, I think, from 31st of January, and it's going to be till 8th of May. You have got CPD hours, 80 CPD hours, so that will also stand out you that on your resume as well. And apart from that, we have got AM and PM classes. Apart from that, recording classes as well. You have got a detailed portal, and you will definitely get an amazing tutors on the portal as well, who have recently passed the exams and who have got a great experience, and they have an idea how the system works. So these are the things. And if you have any question, you can email us or you can even ask now. And looking forward to start with you and see how you all goes. All good, guys?
Yeah, I had one question.
Yes.
So, like when I was searching on the website, there are 2 clinical courses. One is the one with like $2,200 and the other is like $5,900. Are these different or same? I got really confused about both
I
the
think
courses.
it's this one, AMC Clinical course, which I can see currently now on the portal. So yeah, what I can see is this one, AMC Clinical course, 31st January to 8th May 2024.
Yeah, and on the side there is another course that is also AMC Clinical course.
I think that's today one, which is going to be a live session. AMC Clinical course free session 14th of January, which is today. If you can just go simply to Emergency Focus website, which is from Google.
I have a small doubt, sorry. If we get in the clinical course, after the exam, hopefully, fingers crossed, if we clear the exam, would institute be helping us to get the interviews and resumes and everything, or just the course for the?
So we have got this AMC MCQ, like I can give you a good example that once you enter in a good school or in a good college, you know, okay, now in the end of the day, I'm going to be a doctor, I'm going to be a person who had good marks and getting entry into the medical exam. So thanks to Rizwan opening up emergency focus for IMGs. If you will ask me 3 years before, there's nothing like that. So we have got our AMC MCQ course, number 1 step. And then we will ask you to move forward to our AMC clinical course. And then once you've done your AMC clinical course, we have got good options. If you want a GP career pathway, if you got interview prep, I by myself running a complete career guidance support course with a success rate of 35 candidates in the system in 2 months with the job offers. So we have got full packages. So yeah, this is a win-win situation. The most important thing, which, yeah.
If I pay for the clinical one, will I be getting the career guidance as well included, or
No, of course that's a different course, but it's a clinical course now, and that would be good if like a step-by-step approach, get into the clinical exam, follow the advice of your tutors, whatever the strategy and techniques they are telling you, if you're following those things exactly the same, I believe that's 100% win-win situation.
Okay. Thank you.
No worries. Thank you so much, everyone. I wish you good luck. And my special thanks to Faryal and Fawwa for coming today and explaining us the basic things. And we are definitely looking forward. And thanks to Rizwan as well for arranging this platform for IMGs.